Okay, your time starts now. The patient whom you have treated with the combination of alpha blockers and 5 alpha reductase inhibitors, as I said, was not happy because of the side effects due to the finasteride, causing him lack of libido and erectile dysfunctions. You have supplemented him with phosphodiesterase inhibitors, but somehow it is not quite suitable to him. So he is attending your clinics again. His repeat IPS score is 15 with UOL still at 5 out of 6. What is your next steps?
So at this point, I'll counsel the patients that pharmacological treatment hasn't been appropriate in relieving his symptoms. The next consideration at this point will be surgical intervention in the form of bladder outlets obstruction surgery. And I will go through the different surgical possibilities or options for him, including the less minimally invasive ones such as Urolift and Resume, and then traditional TURP or holmium laser enucleation of prostate. I will need to assess his prostate volume to also decide which one may be more appropriate for him.
How will you assess his prostate volume?
So I can do this with a transrectal ultrasound scan, or if he's had any previous cross-sectional imaging like MRI, I can measure the prostate volume from that.
Okay. You haven't had any MRI in the past, so his transrectal ultrasound measurement said prostate is 80 cc, and will it make any difference in choosing the energy source?
Yes. So given that he has an 80 cc prostate, and if I'm considering a TURP here, I will be going for a bipolar TURP for the main reason that the size of his prostate puts him at risk of a TUR syndrome if I were to go for a monopolar TURP. So bipolar will be the preference. And other options would be a HOLEP.
What are the main advantages of bipolar compared to monopolar TURP?
So advantages include elimination of the risk of TUR syndrome, better hemostasis, less transfusion rates when compared with monopolar TURP, and also less charring during resection.
Okay. And regarding the other newer energy resources, which is suitable for this patient?
So holmium laser enucleation of prostate or green light laser prostatectomy could also be options here, or thulium laser enucleation of prostate.
Do you know how this thulium laser works?
So thulium laser compared to holmium laser is more efficient. It has settings which allow you to go really high frequency, which is thought to be more hemostatic compared to holmium laser.
Okay. How the green light vaporization works?
So green light vaporization works using the KTP and the YAG laser at a wavelength of 532, and the laser is directed on the prostate tissue, causing heating and vaporization of the prostate tissue.
Okay. Apart from green light, holmium and thulium, is there any other energy source you can use for enucleation?
I'm not aware of any other sources for enucleation.
Any other newer surgical modalities which can help him?
So Urolift and Resume newer technologies. However, given the size of his prostate, 80 cc, I'll be cautious using these newer modalities.
So what is the guideline? What is the maximum size up to which you can apply these two methods?
So 80 is the cutoff, I believe.
Okay. Do you know how Resume works?
So resume works by introduction of superheated steam into the prostates, causing um, tissue necrosis, which then sloughs off over time to create a channel in the prostate.
Okay. What about Eurolift?
So Urolift involves deployment of um, titanium clips to open up the prostate. It's deployed at strategic positions, depending on the size of the prostate, avoiding the bladder neck to create an open channel to allow bladder emptying.
Do you know what are all the components of the Eurolift implant?
So it's got the no, I'm not exactly sure of the components. Sorry.
Okay. And any evidence to support the prostatic urethral lift?
So there is a recently published 5-year outcomes for Eurolift, but I'm not exactly sure of the figures of this paper. But there is a recently published outcome. Yeah.
Okay. What about the median lobe? Is it amenable to resume and Eurolift?
So the median, initially when these technologies were introduced, surgeons were advised to avoid using them in the median lobe, but contemporary evidence suggests that in trained hands, you could successfully deploy them in the median lobe.
Okay. Is it possible to use Eurolift in patients with acute urinary retention?
There's also evidence to support that they are useful. They can be used in the acute setting, acute urine retention to relieve urine retention and render patients catheter free. However, it's not indicated in high pressure chronic retention.
Do you know about the another modality, ITIND?
Sorry, say that again?
ITIND, ITIND.
No, I'm not aware of that.
Okay. What is the evidence for resume?
I'm not familiar with the paper, sorry.
Okay. If you are doing holmium enucleation for this patient, because you said that may be the most suitable one with the 80cc prostate, how are you going to explain this and get the consent from the patient?
So with the use of a BIOS specific information leaflet, I will explain the risks, benefits, and alternatives of this procedure. For this specific HOLEP, it involves the use of laser to remove or to carry out the prostate in an anatomical plane. The benefits is that it creates a channel similar to a Milling's prostatectomy. However, this is achieved endoscopically, and the results are comparable or slightly better than the traditional TURP. I'll explain about potential risks of infection, bleeding, urine incontinence, or persistence of low tract symptoms. But overall, it is a safe procedure with minimal risk of bleeding or transfusion and good patient-reported outcomes.
So what are the main disadvantages or complications in HOLEP?
So the complication include urine incontinence if the sphincter is affected. This is the main complication. Retrograde ejaculation is almost always present following this procedure.
Okay. How will you remove the prostate tissue which is enucleated into the bladder?
This is done with a musculator, which crushes the prostate tissue and allows suctioning of the crushed prostate tissue out of the bladder.
So how this musculator works?
It breaks the prostate. It breaks the prostate up into very tiny fragments by crushing the prostate and allowing suction of the prostate out.
What are the disadvantages of musculator?
Because of the mechanism, there is risk of damage to the urothelium or bladder or even bladder perforation. So care must be taken when deploying the modulator.
Okay, so what is your post-op follow-up? The surgery goes well, you have done a holmium enucleation, a 3-way catheter placed with irrigation.
So the patient will be potentially talked 24 to 48 hours after the procedure and discharged home if it's voiding okay. I will then see him back in clinic in about 3 months' time with an up-to-date IPSS and a repeat flow rate and a post-void scan to objectively compare his preoperative symptoms and his post-op status.
Okay, and you are seeing this patient in 3 months' time. He has good improvement. His voiding is spectacular. He's so happy, but he has urine leak on, say, climbing the stairs or coughing or laughing. So, what is happening with that?
So he has developed post-op urine incontinence, which is from the symptoms provided in keeping with a stress urine incontinence post-op. I will assess the patients regarding this and initially counsel him on conservative measures to see if this improves, especially pelvic floor exercise.
Okay, if he is not improving his pelvic floor exercise, any other options?
Weight loss, fluid management if he's taking bladder irritants, as well as moderate fluid intake, and also regular voiding to prevent having a full bladder. So these are the conservative measures that he can try. If this fail, given that this is a post-operative presentation, I will discuss him at the functional MDT and arrange a urodynamics for him.
Okay, that's good. Well done. Time's up now. Again, nice flow, confident answers. I'm happy with overall content. The only advice I will say is when I'm posting this video or a similar surgical management of LUTS video which is already posted with maybe Piyush or Ahmed, try to see the video and try to pause the video every slide so that you can get some extra information. I don't want you to go through any resources, only the video, that is more than enough. Because your answers are perfect, more than enough to pass, but I wish you to be a little bit more fulfilling. For example, ITIN, you can bring in few things, and BPA, I mean for the Eurolift you can bring in the lift study, BPH6 study. For the Eurolift in acute urinary retention, you can name the study, the Pulsar study. Those names are not easy, but fortunately you can get them in one place. So maybe your video, which I'm going to produce a link in next another 1 hour. If not with Piyush or Ahmed's video, anybody's video, especially just don't even hear what is happening. Just pause it, see what is in the slide, and then when next slide comes, pause it, get the maximum out of the slides. That's more than enough. That will be a perfect addition to whatever you said, because you're absolutely fine. I just want to top it up a little bit here and there.
Yeah, thank you. I think I'm just missing the evidence for the Eurolift and the resume. So the resource will be good to update that knowledge.
Yes, so because for benign prostate and carcinoma prostate, sometimes examiners can ask evidence themselves, while in other tables, usually it's up to you. If you bring the evidence, that's good. Most of the time, we won't have even the time or the mood to bring the evidence. We always wish to discuss as much clinical, and that's more than enough most of the time.
Yeah. Thank you.
Do you have any questions before we conclude?
No. I think once you upload it, I just need to look at the evidence for those studies, really.
Okay.
And I still got a day to to imbibe them. So
this won't take more than a minute for you. Good.
Exactly. Yeah. Thank you so much. Thank you. That's very helpful. I'll get back to you about tomorrow. So
no worries.
I'll have a look here. Thanks very much.
Have a nice evening.
You too. Bye-bye.
Bye.